Good evening and happy Guru Purnima. On behalf of the President of the Dental Council of India, Dr. Devendra Majumdar, and other esteemed members of the Council, I welcome you to the DCI Virtual Platform for Learning. After a grand success of the first webinar, which was attended by 10,131 attendees, we come to the second webinar. Before we start this webinar, I would like to give you some important instructions. But the instructions are as, please note, at the time of registrations, complete and proper details must be furnished since the same will be captured for generating certificates and CDE points. Request for change or modification in the details will not be entertained at a later time. Note, e-certificate of attendance will be sent to all the attendees on their registered email within 3 days, and will be given to those who have attended the entire session of webinar uninterrupted. Attendees are advised to check their spam or junk mail too. Please note, during the last webinar, the certificates have not yet gone out completely because of the high attendance. Note also that CDE points will be awarded only to the dentists registered with the state dental councils and the tribunals of.
So it's my proud honor to introduce to you, all of you, with our guest speaker of the webinar today. He's none other than a very own Dr. Dhirendra Srivastava. Dr. Dhirendra Srivastava is a very well-known figure in oral and maxillofacial surgery. He is a very, very renowned oral and maxillofacial surgery of India, of course, and he is well known all over the world for his excellent surgery and academic skills. Dr. Dhirendra Srivastava is ex-dean of ESIC Dental College and Hospital, New Delhi, and presently he is Acharya, Oral and Maxillofacial Surgery. And Dr. Dhirendra Srivastava is a member of Dental Council of India, New Delhi. So it's an honor for Dental Council of India to have you, sir. So over to you, Dr. Dhirendra Srivastava. We are honored that you are with us to present on a topic which is very, very important, that is infection control and need of changing oral surgical practice in present scenario. Over to you, Dr. Dhirendra Srivastava.
Thank you, Dr. Virender Goyal. It is an honor for me that you have done my introduction. And first of all, I would like to thank Dr. Devendra Majumdar, President, Dental Council of India, Dr. Saha, Secretary, Dental Council of India, all the executive members of the Dental Council of India for giving me this opportunity to speak on infection control and need of changing oral surgery practice in the present scenario. I would like to say in the beginning that whatever I am going to speak in next 40 to 50 minutes is based on the scientific literature and scientific review. Before starting preparing my lecture, I called upon my colleagues from different parts of the India and wanted to know what are the different problems they are encountering during this pandemic to start their practice. It is worth to say that most of the senior colleagues of the dental fraternity, they are afraid of aerosol generating procedures. This is one of the commonest problem during this pandemic. Every dental surgeon is fear of, and lot of people, they have developed fear psychosis because of this aerosol generating procedure. In the beginning, regarding this presentation, I will say that I have no financial disclosures or conflict of interest to declare. India is a very vast country. As I said in the beginning, I called upon different parts of the country to find out what are the problems everybody is facing. So most of the dental clinics, they can be with reception and a single dental chair clinic, and there can be so many dental chairs in a common dental clinic. Now, the problem of a single dental chair clinic without a reception is different from that with a dental college who are having lot of dental chairs in a single hall. In a single dental chair clinic where there is no reception, we have to depend on only telephonic triage, because once the patient comes, the clinical triage is to be done on the same chair without a reception area. The problem of dental colleges with multiple dental chairs in a single hall are different, because a lot of students and dental healthcare workers, they are present in a same hall, so it becomes like a congregation, and this comes into a very high risk transmission group as per the CDC guide. In addition to this, dental surgeons who are settled in remote areas, they have a different set of problem, because most of the farmers, they come together in groups without any face mask etiquettes or without any social distancing. Problems of young dental surgeons, which are facing lot of financial constraints during this period, and they are also worried about that for opening their dental clinics, they have to spend a lot of money, they have to buy a lot of equipment, they have to buy expensive PPEs. But one thing I would like to tell you, that whatever I'm going to address in this lecture, that infection prevention protocol remains same, whether it is a single dental chair clinic or it is a multiple dental chair clinic in a dental college. See, in USA, January 20th, the first case of SARS-CoV-2 was reported. Similarly, in India also, the first case of SARS-CoV-2 was reported on 20th January. Initially, in the month of March, USA discontinued their dental practice, and they allowed only emergency and urgency procedure. But they reopened, CDC reopened the dental clinic on 20th May 2020, and at present there are 2,085,000 cases in USA, and in India there are 6,48,000 cases. Now, as per the guidelines of Government of India, we are still limited to do practice with the emergency and urgency procedures. Now, how long this can continue? It is a very important question, because if you continue only emergency and urgency treatment for a long time, then routine treatment also becomes emergency. You can see this photograph, this girl of 9-year age, she was having a deciduous root canal treatment done at one of the dental clinic, but somehow due to lockdown, her treatment was discontinued, and they have developed this, and she has developed this abscess. This is the time when we have to calculate risk versus benefit, and it is not possible to completely exclude all risks during this pandemic. Dental health practices are to be upscaled to prevent and treat oral diseases. Now, what are the different concerns of the dental surgeons during this SARS-CoV-19 pandemic? The most common problem is that we are vulnerable to transfer of infection because of close proximity to the respiratory reservoir of this virus. Aerosol generating procedures, they have not created only fear psychosis amongst the dental surgeons, but patients are also worried, and they are not interested in taking their dental treatment during this time. See, as I have shown in my previous slide, this girl, she is continuing with this abscess since last 15 days, but she is not interested in getting her abscess drained. Another problem is for the young dentist is disinfection and sterilization protocol. They are thinking that it is very expensive, and type of PP, there is a lot of confusion regarding type of PP to be used also. But it is my strong recommendation that before opening your dental clinics, you have to follow local regulatory authorities' instructions. During the normal course also, we have been following certain infection control program in all our clinics. But during this SARS-CoV-2 outbreak and after the SARS-CoV-2 outbreak, additional infection control measures for all patients are mandatory. SARS-CoV-2 is a highly contagious virus. One person can infect 2 to 3 persons. So it is our bounden duty that isolating this infected individual is very important for all of us, so that infection can control and this R0 goes down, and once it comes down below the 1, this outbreak will spontaneously end. SARS-CoV-2 virus patients can come into your clinic as a symptomatic transmission. So once a symptomatic patient comes to you, it is our duty that we have to examine the patient. We have to at least write down medicines if he is not so ill. And whatever emergency treatment is required, then we have to offer. And after that, strict aseptic protocol and strict disinfection of your clinic is to be done. The problem which lot of dentists, they are encountering, that they might get a pre-symptomatic transmission patients who is SARS-CoV-2 positive but without symptoms yet. So for each and every case, because these type of cases will keep on coming, because number of COVID positive cases are increasing day by day. So these type of cases will keep on coming to your clinics. So now what is important is that a thorough record of every patient is to be made in your clinic. You have to register the name of the patient, the type of treatment which you have done, what was the duration of the treatment, what PPE you were wearing, what PPE your assistant was wearing. That is very important. Why it is important? Because if you are wearing an respiratory PPE while examining your patient and your contact with the patient was less than 5 minutes, so you need not to worry, your attendant need not to worry, even if the patient becomes symptomatic after 5 to 8 days or maybe little more. Now asymptomatic transmission patients, same problem can arise, so you have to write down each and everything if once and there should not be any problem later on. Environmental transmission, these are the indirect transmission which is not traceable to an index patient. So that is why whoever comes in your clinic, they are asymptomatic patients, and all disinfection and sterilization protocols are to be followed for each and every patient. This saliva is this COVID-19 is basically transmission takes from the oral fluids. Otherwise, there are other virals like HIV virus and hepatitis B virus. They are transmitted through the blood. Indirect transmission with contaminated objects can also take place through instruments, equipments, and environmental services. So strict aseptic protocol, that is sterilization of the instruments and equipments, is mandatory. You can come across a patient who is a positive patient, and with every cough, around 200 million of infected particles with virus, they come out. Similarly, 200 million particles, infected particles with virus, they also come out with sneezing. But there is a difference between the sneezing and coughing. Sneezing is like a ballistic and coughing is not like a ballistic. So whenever patient sneezes and if he's not putting his hand on the nose, then it will go far away as compared to the coughing. Now when patient is speaking, they are transmitting around 200 viral particles every minute. So if the infective dose of this virus, as per the CDC guideline, which was released only a few days back, is 1000 viral particles. So if you are speaking to a patient for 5 minutes, 5 minutes or less, there are very less chances that you will get transmission. While patient is breathing and they are sitting on the dental chairs, there only 20 viral particles are coming out through normal breathing. So you can continue dental treatment for a very long period if they are only breathing and they are not coughing, sneezing or talking to you. But again, it is very important that time period should be restricted. Inhalation of airborne microorganisms suspended in the air for long periods. I'm going to talk in detail about this. Now, another important thing is infectivity and virulence. All viral particles, they are not infective, and all viral particles virulence is not that much that they will infect you. So pathogenic organism of sufficient virulence and in adequate numbers are must to cause a disease. Reservoir or source that allows the pathogen to survive and multiply. It is not mandatory that whatever reservoir in it is not mandatory they all are surviving. Mode of transmission from source to the host, it is a respiratory mucosa. Portal of entry through which the pathogen can enter into the host. In our case, it is again a respiratory mucosa of a dental healthcare personnel. And then whether you are susceptible host or not, that is also to be decided. Now, I have already discussed about the direct contact and indirect contact, and another very important area which has created a lot of fear psychosis among the dental surgeons is aerosol producing procedures. See, I would like to go a little back into the history. Mycobacterium tuberculosis, which is a very highly infectious, contagious bacteria. It was discovered in the year 1882, and till now 2.96 million active cases are there in India, and worldwide there are 10 million cases, and mortality rate is 1.5 million per year. H1N1 virus was first discovered in 1919, then 2009, then Ebola virus, then SARS-CoV-1, then MERS-CoV-2, then methicillin-resistant staphylococcus. All these respiratory viruses were discovered quite long back. And air rotor was first invented in the year 1964. I recall my students' days, even in King George's Medical College, Lucknow, in the Department of Conservative Dentistry. In the year 1978, we were having two air rotor handpiece units. Now we have worked for so many years from 1882, or you can say from 1919, or you can say from 2019, with different type of respiratory viruses. We have been working with air rotor. Just our face mask and host immunity has taken care against these viruses, and till now no cases was reported even for aerosol producing procedures. However, certain bacteria they were found in the aerosols. So why there is so much of panic about this COVID-19 virus and aerosol generating procedure to find out? So we have literature, and according to that we are going to tell you. Compressed air uses for coolant generates aerosols, contaminated microorganisms from the oral cavity. This is true. Saliva has many virus particles. Aerosols generated during treatment may be transmitted. This is the problem. This may is a problem because according to this may, everybody started thinking that viral particles are there in aerosols and they will infect dental healthcare workers. Aerosols generated during treatment remain suspended in the air even after completing treatment. Heavier and larger particles settling down faster. This is true. Settling occurs on all horizontal surfaces. These act as a vehicle for transmission of SARS-CoV-2 virus via indirect contact. This is true, and that is why we need to do disinfection of our clinic after every procedure. But now we have to find out what is the truth about this May. We have been confusing ourselves with the medical aerosols, which are entirely different from the dental aerosols. The main difference between the medical aerosols and dental aerosols is that when medical aerosols are created, because either trachea or tracheobronchial tree is irritated, and whatever aerosols they come out along with the bacteria, they are ballistic in nature. No water is used when we are doing any procedure related to medical aerosols. In dental aerosols generating procedures, we never irritate tracheobronchial tree, and they are not ballistic in nature. In addition to this, water used in handpieces further reduces the concentration of the bacteria. Now, when we are doing an aerosol generating procedure in the posterior area of the mandible or maxilla, the aerosols they are rebouncing the buccinator muscles of both the sides. So these aerosols which are generated, they have no speed to come out with ballistic in nature. Now, pathogens disseminated via droplet nuclei, there are certain requirements for pathogens to disseminate via droplet nuclei. Existence of viable pathogen inside the droplet at the source, that is important. Survival of the pathogen inside the droplet or aerosol after being expelled from the source, whether the pathogen survives or not, that is a big question mark. Retention of its ability to infect after exposure to physical challenges like evaporation, light temperature, relative humidity, also to be noted. These are the factors which are also to be noted, and we are not yet clear whether this virus is viable after coming out with aerosol generating procedures or not, or what is its infectivity rate. Then attainment of sufficient dose to cause infection in a susceptible host, and we have already discussed about this, that around 1000 viral particles are required to infect a susceptible host. So we have searched the literature, and amongst the numerous studies we could find that some bacteria are present in the dental aerosols. So on this study, these studies which they have shown presence of bacteria in the dental aerosols, assuming this, we also thought of that SARS-CoV-2 will also remain suspended in the aerosols. Von Dormalen et al. In a recent study have shown that SARS-CoV-2 remains suspended for 3 hours, but this study was done in an artificially created aerosolized environment. This is not a clinical study. This study shows that the titer goes down with time. But even in this study, the infectivity of suspended organisms has not been determined, and their ability to cause disease has not been evaluated. So this was the shortcoming of this study, and still they cannot say that the virus which are coming out from the aerosols, they can infect anybody. In our extensive literature search, we have not found any study which reports presence of SARS-CoV-2 in dental aerosols. 2 words were feeded for this study: dental aerosols and SARS-CoV-2, dental aerosols and COVID-19. We could find 201 articles, review articles, questionnaire studies on impact of dental practice, recommendations and guidelines based on other airborne infectious agents. No evidence of SARS-CoV-2 was reported in any of the study. No original research, no case report was seen which has shown that dental health care personnel were affected with SARS-CoV-2 due to aerosol generating procedures. In spite of all this, still seeing the current COVID crisis, I will recommend that preventive precautions should always be taken and continued so that this virus is not further transmitted. Surface viability of different viruses. This virus stays up to 72 hours in different like plastic, steel, and all that. So disinfection of all horizontal surfaces after every procedure is mandatory. These are the references which we have come across. Now, another precautions which are to be taken for infection prevention. Pre-procedural rinse is one of the most important part for aerosol generating procedure. For otherwise also doing any dental procedure, pre-procedural rinse is very important. Another very important thing which we have never understood and we have not given any cognizance is ventilation. So special air handling and ventilation is mandatory, and you can see that in all the CDC guidelines, whenever there is a lot of people are assembling in one small area and there is no ventilation, they are treated as a very high risk transmission areas. Asepsis and sterilization, rational use of PPE and administrative controls, these all are important in prevention of transmission. Various procedures like various mouth rinses like povidone, iodine, chlorhexidines, all these have been tried, and we have evaluated around 31 scientific studies to find which pre-procedural rinse is best. Povidone iodine has broad range of antimicrobial agent against bacterial spores, viruses, fungi, protozoa. A study has been conducted and it has shown that povidone iodine, when used as a pre-procedural agent, has persistent effect irrespective of variation in oral hygiene. Also, it showed that the effect remains sustained for a minimum of 4 hours. So the most effective pre-procedural rinse as per literature and recommended guidelines includes 0.2% povidone iodine. The alternative is 1% hydrogen peroxide. You can use 0.2% povidone iodine, or you can use 1% hydrogen peroxide. Rinse duration 15 to 30 seconds, and this you have to watch when your patient is sitting on the dental chair. Otherwise, what generally patients they do, they will just rinse once and keep the cup of the filled with your povidone iodine on the tray, and they will not further do any rinsing. So it has no effect. Air ventilation is a very important area which we have to understand, and which is very important for the decay of the droplet nuclei and aerosols in the room air. I would like to mention that in the present scenario of COVID-19, most of the hospitals in India, they were not equipped to be made as an isolation room. They do not have any special facility like HEPA filter or anything else to contain the virus. So the best thing is that air ventilation has to be very good, and the air exchange has to be monitored. So once you monitor the air exchange, it is said that in an isolation room, if more than 12 air changes are taking per hour, so the virus is contained, and there are very less chances of that virus, that the transmission of this virus will take place, because the droplet nuclei and aerosols, they decay with good air ventilation. This is the maximum air exchange required for an isolation room. For a dental clinic where we are mostly doing non-positive patients, but we are doing lot of aerosol generating procedures, it is recommended that something between 6 to 12 air exchanges must take place, preferably on the upper side, that is close to 12 air exchanges should take place in your clinic. So even whatever aerosols they are having any COVID-19, they will be disintegrated within few minutes, and your clinic will be free of any aerosol infected with aerosol having COVID-19. it is very important to understand the concept and type of ventilation. Type of ventilation is natural, mechanical, or hybrid. Natural ventilation, we all our architects, they have designed our home or clinics as per the requirement of the natural ventilation. From one side air comes and from the other side air goes, and it depends on the buoyancy of the winds and indoor and outdoor density. So we have to just understand that this is the natural ventilation. There is no cost, and this is the best ventilation for any clinics to contain this COVID-19 virus. Mechanical ventilation depends on the fans, and they they drive air inside the room and they take out the air from the room also. So they are mechanical ventilation. The problem is that for mechanical ventilation in the buildings, you have to depend on the electricity, and it is very expensive. Hybrid ventilation is a mixed ventilation. If in your clinic natural ventilation is not enough, you can install some exhaust fans and you can calculate your air exchange per hour, and then there is no problem with the COVID-19. Now, higher the ventilation rate, the more rapid is the decay of the droplet nuclei and aerosols in the room air. This equation tells you that what are the probability of infection for a susceptible person. There are so many factors which decides on probability of the infection of a susceptible person. Number of disease cases. In our setup, we are generally having one patient at a time. Number of susceptibles, number of infectors, breathing rate per person, quantum generation by an infected person, quantum of virus generated by an infected person, total exposure time is very important, and then outdoor air supply rate. What is the outdoor air supply rate? So this all is very important, even for getting infection in a probability of infection for a susceptible patient. In this situation of high quantum production, that is high risk aerosol generating procedures, the estimated probability of infection with 15 minutes of exposure in a room with 12 air changes would be below 5%. But this is basically for a COVID positive or an isolation room. It is not for dental clinics. So the chances of getting infected with aerosol generating procedure further goes down, especially when you do a pre-procedural mouth rinse. How to calculate air exchange? Air changes per hour depends on the cubic feet per minute air into 60/area into height of your room. A very simple way to calculate is that how many windows and door are present in your clinic or in your home. If a window size is 1.5 into 2 meters square and door size is 1 meter into 2 meters square, even with the smallest opening, estimated air changes per hour and ventilation rate for 7 meter into 6 meter into 3 meter ward, which is a very big ward, is 37 air changes per hour will take place if your window is 100% open and doors are 100% open. If they are open 50%, then 28. If they are windows closed and only window is open and door is closed, then only 4. So you have to take care of opening windows and doors whenever you are not working in the clinic, and that will take care of natural ventilation. So the recommendations are for air ventilation and dissipate the viruses faster. The recommendations are architects design doors and ventilator in our clean public home. We closed it for installing ACs. So we are not taking any natural air when we are basically installing ACs. Few natural air may become, only a small amount of natural air may come because our doors and windows are not 100% properly sealed. So what is the good idea is that open doors and windows as many times as possible for the natural ventilation. Desired air changes per hour is the key in containment of the infection from aerosols. Hybrid ventilation is economical and effective, and keep gap in between two aerosol procedures. If you have a single dental chair, you should keep gap and let the aerosol get decontaminated by this natural ventilation. Asepsis and sterilization is a very important thing for containment of this virus and for transfer of this virus, transmission of this virus from patient to healthcare workers, or from healthcare workers to the patients, or you can say indirect transmission. Aseptic protocol needs to be understood, and it needs to be, basically you have to assimilate what is aseptic protocol. If you understand aseptic protocol and you assimilate aseptic protocol, I am sure within 2 to 3 months your antibiotic prescription will go down drastically, because then you will start believing on your aseptic protocol. These two small sentences, they tell you each and everything about the aseptic protocol. Touch me not if you have touched others. A virgin saliva or a virgin patient who is not infected with the COVID-19 virus, if you touch their saliva after touching the other objects, then you will infect the saliva. The other way around is that don't touch others after touching me. If you have touched an infected saliva, don't touch any other things. Otherwise, you will infect whatever those objects are. This others, which I have said, touch me not if you have touched others. This others is a very huge list. This can be your face mask, this can be your head cap, this can be your face shield, this can be your own clothes, this can be clothes of the patient, this can be your chair light, this can be your all the switches and buttons of your clinic. So what is what you in these slides you will see that one of the doctor is wearing all the PPEs. He is examining the patient, and after examining the patient, he is touching the light with sterile gloves. Sterile glove remains sterile only when you are touching a sterile object. Decontaminated objects or disinfected objects are not sterile at all. Sterile means an autoclave objects. Now another important thing is this patient. She is touching her oral cavity, and she is an infected person, she can transfer the COVID-19 virus to so many places, whatever place he will touch. Similarly, the doctor if is touching and a drape of the patient which is not sterile, again it becomes contaminated. You should not touch switches of the chair. You should not work on your computer keypad. You should not touch your face mask. You should not. This all is very important for aseptic protocol. The doctor is taking the prescription. See, I am emphasizing again and again that there is no use if you are touching any other object which is not sterile, even with a sterile gloves. Nowadays, I have seen that a lot of people, they are wearing nitrile gloves, which are unsterile, and they just just put some alcohol on the on non-sterile gloves, and they think that they become sterile. It is not like that. So sterile gloves are differently packed, and they are sterile. During this COVID-19 period, there is no place for a sterilizer or a boiler. One has to place this boiler with a pressure cooker or any type of autoclave, because there are so many instruments which cannot be sterilized of a boiler. So any autoclave is must. Whatever autoclave you choose, you have to buy one autoclave. This is the most simplest autoclave. This is pressure cooker type autoclave. It works very well. It can work in the area where no electricity. You can use gas for sterilizing the equipment. The only problem or little problem with this type of autoclave is that sometimes your instruments or your drapes which come out after the sterilization, they are wet. Advantages of steam sterilization: non-toxic to the patient staff environments, easy to control and monitor, rapid microbicidal, least affected by organic inorganic soils, rapid cycle time, penetrates medical packing device lumens. The disadvantage that they are heat sensitive, but during this COVID period, I will advise everyone to even sterilize their scissors which they are using after with steamer sterilizers or autoclaves. Type B autoclaves, they have come with the added advantage that they have a pre-vacuum cycle. So all the instruments, they will come out dry. And another advantage of type B autoclave is that there are different cycle. So accordingly, you can you choose your cycle according to the whatever equipments or instruments, whatever instruments you are sterilizing. If you are using paper and plastic pouches, they remain the instrument, they remain sterile for up to six months. So need not to be sterilized again and again if you have once sterilized. UV light sterilization and disinfection as to a common use nowadays. However, this is a very old concept. We were using this in our operation theaters for sterilization, for disinfecting the operation theaters quite long back. But now during this COVID-19 period, lot of people are interested in buying UV light, and there is lot of commercial promotion to the UV light sterilization disinfection. So we have to understand what they do. UV light C is the one which is used for UV light sterilization and disinfection. They have 100 to 280 meter waves energy length, and they are effective in killing the microorganisms, acts by destroying nucleic acids and disrupting their DNA. Now kill rate is at 40 to 65% relative humidity. This is very important. If you are going to buy light sterilization, then it also the temperature range should be between 21 to 24 for best effective effectivity of this UV light sterilization. If source to target distance is less, intensity is high, and they will treat a less area. If source to target distance is more, then they will treat the intensity will be low, but they will treat more area. So if you are going to choose a UV light sterilization or disinfection, you have to calculate the area which you have to disinfect, and accordingly you should buy. Exposure time is 20 to 30 minutes for disinfection. UV light sterilization, as I have said, sterilizer, they kills 99.9% of germs and easy to use, kills all kind of microorganisms including drug resistant bacteria. Disadvantages are they are dangerous to humans. So protective shielding should be with UV C lights. UV C light can also cause damage to certain plastics and rubber materials over time, and UV light can cause skin cancer, but the chances of getting skin cancer with UVC light are very less because it's less penetration. Another important thing which lot of people they are not doing, and a lot of people they are asking that we need to sterilize dental handpieces, and so I would like to bring forward that what are the reasons for which we have to sterilize your handpiece. They have potential for retracting oral fluids into internal compartment of the device. Retained patient material can be expelled intraorally during subsequent uses. When you are using this again, then it can be expelled, which is carrying microorganism. Probability of retention of viral DNA and viable virus inside both high-speed and handpieces and prophylaxis angles are very high. Restricted physical access limits their cleaning. So inside of the air rotor can be cleaned, and by any means of the physical means. And it is always recommended that run discharge the water or a combination for a minimum of 20 to 30 seconds after each patient. Only steam can effectively sterilize dental handpieces, so you have to autoclave after every patient. Neither surface disinfection nor immersion in chemical germicide is an acceptable method of sterilization for the dental handpieces. Saliva ejectors too, they negatively they transfer the viral or bacteria into their tubing. So after every procedure, your salivary ejectors tubing are to be disinfected. That is very important, because they might contain viruses and which are transmitted into oral cavity when you are doing any procedures. Then radiology, if you are taking an IOP X-ray, or whether with the film or sensor, any gagging reflex should not be stimulated at all. A dental radiologist who is doing radiology, they should ensure that they are not infecting any of the dental radiology equipment. They have to wear proper gloves and PPE gown for doing any dental radiology work. Holding and positioning devices should be sterilized before use. Film sensors should be covered with disposable sleeves. Discard sleeves in such a manner so that films of leak sensor do not get contaminated. Handling of the extracted teeth to be disposed of in yellow bags. Extracted teeth with amalgam filling should be kept separately in a pack and have to be discarded as per the DCC guideline. Sterilize extracted teeth that do not contain amalgam if they are to be used for educational purpose. Handling impression and prosthesis. Impressions, bite registrations, occlusal rims should all of these things should be disinfected as per the manufacturer's guidelines before they are sent to lab. Very important step. Then material being sent to laboratory should always they should always carry an information whether they have been disinfected or not. If they have not been disinfected while handling these impression materials or bite registrations, the lab people, they have to wear all the PPE and gloves, and then only they should, and then contaminate, and only then they should do the further work. Personal protective equipment is these days everybody is thinking of that which personal protective equipment is best. Personal protective equipment selection depends on so many factors: infectivity of the microbial agent, mode of transmission of the disease, severity of the disease and case fatality rate, to type of exposure, duration and amount of exposure, level of comfort offered, which is very important, ease and use and duration of time taken to don and doff, risk of contamination of and exposure, pre-existing illness and availability and cost. Since the respiratory tract is the main portal of entry of the virus, the respiratory tract should be shielded. Each and every person who is working in the clinic, they should have a respiratory protection with the help of N95, or these are same FFP2, N95 or KN95. They are must, because the virus is being transmitted through the nasal and oral mucosa. Wearing of the goggles is also important. The face should also be worn. Each and every person who is working in the dental clinic. Intact skin serves as a proper barrier against the SARS-CoV virus, but also as a vector for transmission. Hence, hygiene of dental healthcare workers, other than hand hygiene, is also required. Whatever I mean is that whatever part of your body is exposed, it can act as a vector for transmission of this virus. Transmission via surfaces like clothing can be prevented by careful behavior, no touch, or by wearing A sash-proof long-sleeved apron over standard protective clothing is must when you are dealing with this virus. Now, what is the difference or what is the effectivity of a surgical mask as compared to the N95 mask? Protection factor of N95 mask is 8 to times greater than the surgical mask. Protection level provided by N95 or FFP respirator was much better compared to the surgical face mask against particle size ranging from 10 to 18 nanometer. So these are the advantages. There are so many advantages of N95 mask over the surgical mask, and the most important advantage of this N95 mask is a very proper fit as compared to the surgical mask, and their filtration rate is also better as compared to the surgical masks. Now, how to choose a personal protective clothing, it is very important. A systematic review has showed that a systematic review provided a low to very low certainty evidence that covering more parts of the body leads to better protection, but usually comes at the cost of more difficult donning or doffing and less user comfort, and may therefore even lead to more contamination. What this means is that it is very important for us to choose a personal protective clothing for which you can wear easily. The donning and doffing of that it is easier, so that you are not personally infect yourself at the time of the doffing. It has been observed that improper PPE doffing practices may result in contamination of healthcare workers' skin and clothing. A PPC with good water repellency and water resistance is effective in providing a desirable protective function against droplet splash, but has poor air permeability. So if you are using a PPC as for aerosol generating procedure, or you are expecting a splash, then it should be a water repellent or a water resistant, because they have less of air permeability. And if you have to wear this this PPE for very long time, especially in the humid wear, so it becomes very uncomfortable to wear these PPEs. Surgical gowns is also appropriate. It is cost effective, air permeability is fair, and the level of possible hand contamination is minimum, because the cloth of the surgical gown, they are permeable, they permit air, so they are easy to wear, and they absorb fluid as well as splash, and they absorb the virus also. So the chances of cross infection from this surgical gown is less as compared to the PPC with high water repellency and water resistance. If you are expecting lot of splashes or droplets, then you can wear an additional apron over this PPE up to the trunk level. PPE has to be decided according to the use by dental healthcare worker. Administrative control, arrange things so that social distancing between patient and healthcare workers is maintained when healthcare workers are not wearing PPE kits. So a lot of things are to be, you have to train your clinic boys or your assistants, because they have to also understand during this pandemic, they have to understand the problems which we are getting encountered for transmission of this virus. So to conclude infection control, I will say it is wiser and easier and cheaper to understand and assimilate aseptic protocols and disinfection for prevention of transmission of COVID-19. Buying commercially motivated products without understanding its utility and effectivity will soon have a place in a storage room after the end of COVID-19. Before buying any product, you have to find out whether they are, how much is the utility and how much is the effectivity of that. Don't buy like that. Hepatitis B and HIV taught us how to respect about blood-borne pathogens. COVID-19 is He to teach us infectivity of the saliva. Air purifiers, HEPA filters, and other filtering units, they are of no use if your surface cleaning or if your disinfection is not proper and you do not have a natural ventilation. Touch me not is the key for prevention of transmission of this virus. Need of changing oral surgery practice during COVID-19 pandemic. Infection prevention and disinfection protocol remains the same. There are certain changes which are to be made in oral surgery practice under local anesthesia, and certain changes are to be made in changes required in oral surgery practice for under general anesthesia. As per the AOCMF guidelines, airway management, rapid sequence intubation by the most experienced anesthetist on the team should be done. All team members should be outside the operation theater till the patient is intubated. The patient has to be transferred direct to the operation theater, and there has to be, if he is a COVID positive patient, so there has to be a separate operation theater for the COVID positive patients. These operation theaters should be equipped with the HEPA filters and laminar airflow. Now, how you have to finally decide whether you can plan a surgery or not. This is based on basically on the based on the basis of PCR testing and antibody testing. If a patient who is coming to you has come to you, he is PCR negative but he is antibody positive, carry out the surgery, discharge the patient, and no need of any testing in between. If the patient is PCR negative and antibody negative, carry out the surgery, discharge the patient, but in between you have to get every 6 to 7 days you have to get his PCR testing done. If the PCR is positive and antibody negative, postpone the surgery if it is an elective surgery, and once the patient recovers, then only you should plan the surgery and do all the testing again. Extraction and minor oral surgical procedures under local anesthesia. Avoid intermittent spitting by the patient. Use high vacuum suction, efficient assistant personnel to help operate with good speed. Use of micromotor at low speed with slow drip irrigation should be done. You can use air rotor also. These are the old guidelines. Use scalpel instead of cautery. Laser hemostasis to be achieved with chemical or mechanical measures. Disposable sutures should be used so that patient subsequent visits are not required. Follow up on telephonic consultation should be done. Patient should not be called recalled every now and then. If MMF is required with wires, or it can be done with the screws, whatever is easier in your hands, you can do that. Incision and drainage to be carried out extraordinarily whenever possible. Keep minimal equipment in the consulting room. Remove unnecessary items, frequently cleaning of doorknobs and tables. Additional precautions to be taken while doing aerosol generating procedures. Decontamination of operatories to be done after every patient. The clinic and reception area should be wiped with multi-bucket technique, first with water, then detergent, and then with 0.1% sodium hypochlorite. Door handles and surfaces that are frequently touched need to be mopped and wiped with disinfectant. Wiping and disinfection to be done after every patient. All instruments have to be disinfected and sterilized as per manufacturer's instructions. Disposable instruments have to be carefully disposed with appropriate receptacles. CMF trauma management should be performed by an experienced surgeon with a minimum number of assistants possible. In general, closed procedures, if internal fixation is required, the extent of the reduction are to be favored. Special recommendations are based on the anatomical region where we have to do the surgery. General instructions for trauma surgeries is scalpel or monopolar diathermy for mucosal incision should be preferred. Bipolar diathermy for hemostasis on lowest power setting should be done. Avoid repeated suctioning, oblique irrigation, self-drilling screws to be preferred. High-speed drills to be used with additional precautions. Indications for urgent surgery, life-threatening maxillofacial infections requiring urgent surgical intervention should be done. Cases in which a worse outcome is expected if surgery is delayed for more than 6 weeks, that is a squamous cell carcinoma of the oral cavity, oropharynx, larynx, and hypopharynx should be immediately done. Cancers with impending airway compromise or a rapidly growing bulky disease, they come into urgent surgery. High-grade or progressive salivary cancers, rapidly progressive cutaneous squamous cell carcinoma with regional diseases, salvage surgery for recurrent oblique persistent disease, and high-grade sinonasal malignancy without equal efficacious non-surgical options are indicated as an urgent surgery. These are the references which I have used for this presentation. This presentation will be uploaded on the DCI website, and if anybody wants, they can download these references for their use, and they can do further studies. At the end, I would like to acknowledge few of my colleagues, Dr. Romani, Dr. Shweta, Dr. Vinita, and Dr. Akanksha, who helped me in getting this presentation made and who have done a lot of research work, scientific studies to find out what is best. Thank you very much for patience hearing. Thank you once again. Once again, I would like to thank Dr. Majumdar, Dr. Sabyasachi Shah, and all the members of the executive committee and DCI members and other members who are involved in these webinars. Thank you very much.
Thank you, Dr. Virendra Srivastava, for an excellent evidence-based presentation. We would take some questions which have been put up by various participants. Now, some people would want to know what should be the time between the two patients which can be taken in, and what are the chances of acquiring infection in the clinic?
See, if you are following all the aseptic protocol, if you are decontaminating your clinic, then there are chances of getting infection even with a carrier are very less, and it also depends on the timing and which type of PP you were using when you were carrying out the procedure. So that is why in the beginning only I mentioned that you have to record each and everything, and there are, I don't feel there is any chance to get infected from doing any procedure on the patients if you are taking all the precautions. And yes.
There was another question which was asked was, would you recommend use of infrared thermometers versus pulse oximeters?
Yes, I will recommend, but see, I have not mentioned because in DCI advisory which was issued a few months back, all this is already mentioned that you before you take a patient, you have to do a triage. So it is always recommended for triage, and one should always do take a temperature. One should always take a brief history to find out whether there are any chances in this patient, or whether he's COVID positive or he's a susceptible patient. So always these things are to be done.
One more question was, is there a requirement for chloroquine prophylaxis for the dental practice?
A very tricky thing, because as per ICMR guidelines, sometimes they recommend that you should take chloroquine, sometimes they don't recommend. So I will say as a prophylactic measure, there is no harm, because we have been taking chloroquine in India so long for malarial diseases. So I don't think there is any problem if you take chloroquine prophylactically.
And one last question would be, what you've already elaborated in, would you again tell what emergencies would you want to take in general dental practice, like when patient come with toothache? Would you recommend extractions, or would you want to wait for those patients?
No, I think if it depends on your clinical judgment. If you decide that you have to do extraction and it is an emergency, there is no harm in doing extraction. And if you still feel that with the root canal, this patient can, the tooth can be saved, then you open the root canal. So it is your clinical judgment that whatever you have to do, you can decide, and at least emergency treatment like root canal opening, and if it is 100% it is required that extraction has to be done. There is a lot of swelling or it may lead to abscess formation, so you have to do the extraction. There is no harm at present.
Thank you, Dr. Dhirendra Srivastava. It was an excellent presentation, and I am sure you have sent the message across in which people would be more confident, dentists would be more confident when they go to their clinics, and would be, it must be much easier for them, because there has been always a lot of questions posed, whether I open my clinic, whether I do any procedures, or whether what is the future in store for me. I am sure after this presentation, a lot of doubts would have cleared. Now, I must now come, my duty is here to thank Dr. Muzumdar, our president, who has been a guiding light behind these webinars. It was his idea, which he said that we must have something for each and every dentist of this country. And seeing the response, I think, sir, your vision is being fulfilled. I thank Dr. Sabyasachi Shah, the secretary, who is very dynamic and who has always been in forefront in getting all the aspects of these webinars together. There have been a number of committees which have looked into these webinars, the members of the Dental Council of India, staff of the council, technical support team, which have spent a lot of time. And personally today, I should also thank Dr. Virender Goyal, who filled in because there was a major network failure in Goa because of heavy rains and storm. I missed out introducing Dr. Dhirendra Srivastava. I apologize for that. And we would be very happy to have you all for the next webinar, which would be by the Conservative and Endodontics Department. It is COVID and its implications in conservative dentistry and endodontics on 12th July 2020 at 4 p.m. The presenter is Dr. Mohan Bhuvneshwaran, and the moderator is my dear friend Dr. Jagat Bhushan. Now, with this, we've come to the conclusion of this webinar. However, please remember again that there would be a feedback form on your screens immediately after this webinar. It will remain there only for a few seconds. Kindly fill in that feedback form. It will help us to improve. And also, that would conclude your presence in the webinar. Thank you once again. Hope you have a pleasant evening and a wonderful COVID-free future.
I would like to thank Dr. Vikas. Are you listening to me? Dr. Vikas?
Yes, I am listening.
Thank you very much for the nice introduction. Thank you once again.